Okay, so my article, I believe, is sort of one of the classics, I've been told by Dr. Kurtz, on the maintenance or the generalization of treatment effects of PCIT from home to school. Right. All right, so quick review of some of the past research. They said, looking at past research, there wasn't a lot of it out there on generalization from parent training programs, looking more broadly than just PCIT. And what they did find was inconsistent. So some studies in the past showed no improvement following parent training in the school without direct intervention in the school. Some studies in the past actually found a link between parent training and increased challenging behavior in the school, which they thought might have been a behavioral contrast effect, which I had to look up. But essentially, sort of those of you with more kind of behavioral background probably understand it. But the idea that sort of like if a behavior is reduced in one setting, maybe it's, kind of pressure in one place is leading it to squeeze out somewhere else. And then there was a study that showed some more positive results looking at the impact of social learning, family therapy, and parent discussion groups, but there were some limitations in the methodology that made it kind of hard to interpret. So some mixed findings and some limited research prior to this. Okay. All right, and then in looking at those past studies, they also found some other limitations. So in order to look at generalization across one setting to another, it was necessary to determine that the behavior in the home setting improved. Behavior in the home setting, I shouldn't say occurred, it should say the home setting improved before exploring generalization, and that the children receiving treatment had behavior problems in the school setting, which makes sense. You want to make sure that there actually is a measurable improvement in the home behavior and that there's a problem in the school. And looking at the past studies, there were some instances where the child compliance in the home only increased marginally. And in some past studies, some children were displaying normal school behavior before treatment. So that could be one of the reasons for some of those mixed findings. So this study was looking to sort of fill that gap. So looking at school generalization in children who demonstrated severe conduct problems in both home and school before PCIT, and had clinically significant improvements in their home behavior after PCIT. Okay, so the method, there were 30 children aged 2 to 7, and they were broken into 3 groups. So there were 10 in a treatment group. The treatment group criteria were that they had ECB scores above the clinical cutoff. Their DPICS compliance levels were below typical compared to non-referred children. And then teacher ratings on the RCTRS were 1 standard deviation above the mean for conduct problems or hyperactivity. Then there were 10 in a normal control group and 10 in a quote unquote deviant control group. And so for each treatment group child, there was 1 normal control and 1 deviant control selected from the same classroom by someone other than the lead teacher who kind of knew the classroom. And there was some analysis conducted to make sure there were no significant differences between the groups. So deviant control was a child who also displayed some level of disruptive behavior in the classroom as a comparison. It's a little slow here. All right, measures for outcomes in the home. There was DPICS observation done 2 times before treatment and 2 times post. They were only measuring compliance with commands from the parent, as well as deviant behavior, which is defined here: whining, crying, smart talks, destructive behavior, physical negatives, and the ECB. And then the measures for school, there was a classroom observation component using a coding system where coders observed 3 categories of behavior for each child in each of those 3 groups. So they were coding appropriate versus oppositional behavior, comply versus non-comply versus unsure or no command given, and then on task versus off task. And so with that, it resulted in numbers for percent appropriate behavior, percent compliance, and percent time on task. And there was an interval sampling procedure used. So each coder would observe each child sequentially in 10-second increments. So 10 seconds to observe, 10 seconds to record their observations, switching to the next child, 10 seconds to observe, 10 seconds to record. And that was done similar to home 2 times before treatment and 2 times post-treatment. And the coders were blind to the group assignments to prevent bias. And then there were teacher measures, the RCTRS, which was used to help identify hyperactivity. It's not that the CESP was used, but I don't have that in here. Okay, so the treatment group received 14 weekly sessions of PCIT, so 7 CDI, 7 PDI. There was no direct intervention in the classroom. And after PCIT, all 10 of the children in the treatment group did meet the criteria for that next step of looking at generalization, because they did show clinically significant behavior improvements at home after completion. All right, so the results showed that successful completion of PCIT was associated with improvements in some school behaviors, and then it kind of breaks down which school behaviors improved. So the main evidence for improvement in school behavior related to conduct and oppositional problems. So in the classroom, the treatment group showed significantly greater improvements on measures of oppositional behavior versus the normal control and the deviant control. They improved to within normal limits on the percentage of appropriate behavior and compliance, and they improved from outside normal limits to within 1 standard deviation of the norm on the CESP and RCTRS scores. The generalization was not found related to hyperactivity and inattention. There were improvements in their percentage of time on task and in the RCTRS, but was not significant compared to the deviant control. And so some hypotheses about that were there could have been improvements in those behaviors at home, but perhaps there was a different level of demands on their attention in school, or possibly the PCIT is less effective for ADHD than for ODD, conduct disorder type of things. And the generalization was also not found for peer relationships. And they said that was not really surprising, because it was a second level generalization. It would have required children to generalize improvements in their behavior from home to school, and for the school generalization to impact their peer interactions. And it also noted that while they didn't show more, the treatment group didn't show more improvements in this area than controls, they did demonstrate some growth after treatment, which they said could have also been due to just the impacts of regular growth and development. They also hypothesized this could also be that more time is needed for this to generalize, and suggested that additional social skills treatment might be beneficial for some children. Other results, they found that the parents, the parents' magnitude of reports of behavior change improvement was significantly related to the magnitude of change reported by teachers. So their scores, parent-teacher scores, were not correlated pre and post, but the magnitude of change was, which is further evidence that the behavior change in school was related to the behavior change at home. And the study showed evidence to contradict that behavioral contrast effect hypothesis. There was only one child in the treatment group who had evidence of increased poor behavior at school, and only on one measure. Okay, limitations. The treatment group children did show more severe behavior problems than the deviant control children. So there's a possibility that improvements in that group were attributed to regression toward the mean. It was a small sample size, 10 children in the treatment group, 30 total, and teachers were aware of which children were receiving treatment. There was no way around that really in the structure of this. So there was a possibility that teachers had a positive expectation of change. But they also noted that the consistency of teacher reports with those of the observers, the blind coders, suggests that this did not have a huge impact on teacher expectations. Okay, and then just possible mechanisms for generalization and future directions. So how they thought that the generalization maybe happened, or what was sort of the mechanism there. So one hypothesis was that the focus of PCIT, which was on changing behavior through that improved parent-child relationship, had more of an impact than past parent training programs from the previous studies that were more focused on behavioral change. Very specifically, PCIT does behavior change, but through that relational piece. There was a thought perhaps that CDI skills support generalization by increasing pro-social behaviors. The possibility that the child comes to expect praise for those pro-social skills from adults, and then when they're using those skills in other settings, they're getting other reinforcing feedback that's sustaining those behaviors. Possibility in a different non-behavioral lens that perhaps CDI is impacting in a positive way the child's overall self-image or level of anger. Possibility that PDI is teaching habitual compliance response to directions that's generalizing to other adults beyond just parents. possibility that essentially this PCIT introduced more structure to the home that better mirrors the structure at school that helped with carryover. And then possible future directions for study to look at, do improvements in oppositional behavior maintain over time? Does maintenance of behavior in school relate to parent maintenance of PCIT skills at home? And if maintained at school, does improved behavior over time impact peer relationships? If given more time, would the peer relationships improve?
All right, tons of information in there. So, thumbs up, thumbs down. Does PCIT generalize to school settings?
For some.
Based on a sample of 10 kids compared to 10 kids compared to 10 kids, right? So we should be mindful of that as we're teaching new folks coming in as PCIT therapists about this evidence. I think it's important to teach them about strength of evidence. Some of your trainees will come in with more experience, less experience looking at research studies. Interesting that the findings didn't generalize to ADHD behaviors. And you suggested, as they suggested, maybe PCIT doesn't target that so well. There's been more evidence specifically looking at that, and the generalization has been, or the treatment effects to ADHD core symptoms has actually been better when that's what people are actually targeting. So there's good information in that regard. And one of the research and briefs at the conference summarized that work. And then in terms of generalizing to peer interactions, some people think, including Howard Abacoff, Russ Barkley, very well-known scholars in the ADHD world, that the ADHD brain may have a deficit in the ability to generalize. And so people like Russ Barkley have argued that the only social skills interventions that make sense are those done at the point of performance. So you can get 7 kids in a room at 57 West 57th Street, and they'll learn all their points on Wednesdays from 3 to 4:30, and then they'll fight in the elevator on the way down as to who gets to press the L, because only one person gets to press it for real, right? So there may be a core deficit in that regard. I love the information about the parent and teacher correlations. I remember looking at CBCL when I was first coming up. Parent-teacher correlations are about 0.3, if I remember. It's either like 0.29 or 0.38, something in there. But they did a lovely analysis, as you said, Kate, looking at the parallel and magnitude of change. That was an interesting assessment. Yeah, so great review.